Good afternoon, and thank you for attending our webinar series today. We do a webinar each month in Blue Cirrus, and we bring guests in, like our esteemed guests today that we have, and others, and we talk about topics that you've asked us to talk about. So if there are other topics that you are interested in along the way, please pass those on to us. We would love to do a webinar series or topic on something that you are interested in or need help with. We always like to share lots of good nuggets of information that you can take back and use in your own work, in your day-to-day practice in healthcare. So today we are going to talk about why healthcare loves data. And this kind of flows into the February Valentine's theme a little bit here. So we know that in our day-to-day work, we always need data to be able to do a better job, but healthcare is particularly interested in data and slicing and dicing that data. How are those individual patients improving, and how is our community improving as a whole? And I have the absolute best folks to talk about healthcare and healthcare data today. And that is Rebecca Freeman, who is the Vice President of Health Informatics at UVM Health Network, and Sherry Hess, the CNIO of Banner Health. So I have short bios for the two of them, but essentially both of them are extremely experienced. In Rebecca's case, she has extensive experience both in healthcare IT as well as practical experience as being a registered nurse. She has unique perspectives from working in diverse different backgrounds and has kind of an unorthodox yet effective approach to HIT execution. So I think you'll enjoy her take on healthcare and healthcare data, and welcome, Rebecca. In addition,
thanks. I like the use of the word unorthodox, by the way. ER nurse sarcasm is kind of what she means, and a general failure to follow rules. So thanks, Michelle. Unorthodox.
That's right. Those are the kinds of words we use to describe unique, unorthodox, passionate. Those are good words. And Sherry Hess, another great friend and experienced professional in the industry as an RN with over 30 years in healthcare and healthcare IT. She's the strategic liaison between clinical IT, clinical leaders in IT, and also works hard to address information and knowledge needs of healthcare professionals and patients to promote safe, effective, and efficient use, of health IT. So welcome, Sherry.
Thanks. Great. Glad to be here and have a great conversation with all those in attendance.
That's right. Absolutely. And I'm Michelle Hager. I'm the managing partner of Blue Cirrus Consulting. Happy to be here to facilitate and work with these ladies. So first off, I will tell folks that we're going to talk about several different topics. And first, we're going to start with why data is important. So Sherry and Rebecca, why is data so important?
Thanks, Michelle. It's Rebecca. You guys will figure out the difference between me and Sherry, I think, pretty quickly. I'll just kick off. I do want to say this is an open forum conversation with folks who don't mind being interrupted. So we can certainly get to the end of these. I think we have 6 or 7 slides. Sometimes we'll remember Sherry more than me to ask if you guys have anything to input. But if you want to ask a question or add a story, please feel free to jump in, and we will happily field your midstream conversations. So why is data important? You know, this first one, I laugh. It's like, yeah, okay, we cut and pasted that from somebody's tweet. And we didn't, but we could have. It assists teams in driving care towards high value, high quality, best practice. That's the idea. I will at least 3 or 4 times in this conversation point out all the reasons that sounds amazing and is almost impossible to get to. A lot of it has to do with culture. A lot of it has to do with history. But the fact is, in our EHRs, we really do have the ability to offer, especially if we get creative with non-EHR data, we can pull together reports dashboards. We can offer help to the bedside staff at the point of care and take that data all the way up to the C-suite. But there is a lot of stuff that has to happen in order for that to become a reality. And even more so now in the land of 21st century cures and information blocking rules, we are starting to share a lot of data with patients. So there are great examples of how we can use data in a great way and the outcomes that we can impact. And so Sherry actually has, to kick us off, a couple of good examples of how she has done this in the past. And then I will leave it to her to offer thoughts on 1 through 3 that I didn't cover. I also talk 150 miles a minute, so good luck interrupting me.
Well, we both are the same way there, but please, we do want you guys to interrupt or put something in the chat and add your thoughts, as Michelle will be watching that too. So as Michelle had stated, and for those of you who may not know where Banner is, we're on the West Coast, or the West, I should say, mostly in Arizona, but 6 states on the West. And so when you think about over my years of experience, I've worked at multiple different organizations. Prior to Banner, I was in the Denver metro area, at an organization that we used a lot of lean principles. And that's really where I started using Pareto charts. And for those that haven't used those before, it's a great way to analyze problems or causes of a process that involves the frequency. So you don't want to focus on, I'll give you one example, when we are looking at improving our start times in the operating room, well, the last thing you want to do is focus on something that's only going to move the dial maybe 10% of the time. So this is where you create that Pareto chart to why are we not starting our OR cases on time. And when we did that and really looked at that data daily, it wasn't a monthly thing. So every morning they did a huddle and utilized a visual management board, and that leadership team came together and said, okay, yesterday, why did we have 5 that didn't start on time? Was that the physician was late? It took them longer to get through the registration. Why was that? Oh, well, there were 5 people in line and only 1 person, and they were here at X time. So it's key if you have to find those tools for those improvement areas on using your Pareto charts. Another thing we've looked at over the years that when I've come to each of the organizations that I'm at, I ask our safety quality team, I ask our nursing leaders or clinical leaders, where do we have opportunities for improvement? This is where that data comes in. And the nursing leaders had been asking for help for many years on lab specimen mislabeling. For many of you that are nurses or clinicians in the field, that can, well, it sounds pretty easy, but if that nurse or that lab tech is drawing them, there's multiple things that you have to do or it gets rejected from the lab. Well, one of those largest areas of improvement was around the lab mislabeling. I should specifically say when we looked into it, it was nurses that were doing the majority of the lab mislabeling because that wasn't their only job that they did. Unlike lab, well, they had a few, it was mostly the nursing. So we took that information, that data that proved, hey, this is where we are making our errors. And then I was able to secure funding to improve that through a technology of scanning the patient's armband, printing the lab specimen label real time at the bedside. So you weren't having to go out to the desk area where there was a lab labeler that would print it there. And then maybe you only grabbed half of them or you grabbed the wrong patients and there were multiple. Very complex process. But during that, what we did was we took that from being the largest area of opportunity for nursing to almost zero labeling issues after that. So that's where we've used that data in the past to really make a difference and think about improving the patient satisfaction, right? The last thing you want to get is not only stuck once, but twice for the same lab that's being drawn.
Exactly. And I think one of the things that you're pointing out is really process improvement. You utilize that data to improve your process, which improved therefore quality. Is that an accurate way to describe that?
Correct.
Yeah, I think that's great. I also asked a question that in the chat that Rebecca promised to answer about, isn't it possible that that you have too much data?
Yep. And well, if we go to the next slide, Michelle, I'll give you my answer in the framework of kind of this next slide. And I'll take the lead on talking on this one too, because the next slide is almost entirely Sherry's, because it's examples of when it works well. And I frankly didn't have a whole lot of those to offer, but I can whine. And this is a great slide for whining. Documentation, we hear a lot about documentation burden, and it is across every role in the care team, that between requirements for billing for providers to a million extra flow sheets for inpatient nurses. Everyone has a very fair gripe most of the time about too much documentation, extraneous documentation, systems not being usable. But when we talk about data and analytics, you can't separate those things. Unfortunately, they are not divorceable. If you have crummy documentation or low usability, your data and analytics efforts are going to be really hampered. And so what we find lots of times is we increase documentation and burden in the need to get clean data, because we can't pull it from the existing data set. So we develop a new flow sheet or a new pop-up that drives you towards something. And so that can be really ugly. And I say that for number 1 and 2, to get back to Michelle's question about, can we have too much data? It depends on who you're asking. I love big data. I love cognitive computing and predictive analytics. And I would say, no, you can't give me too many data points, because the more data points I have and the more history I have on those data points, in all likelihood, the better I'm going to have predictive models right out of the gate. It's really important. On the flip side, at the point of care, when you're caring for a patient, we frequently now have just piled on. Everyone who has a question about anything gets to put it in the record, and it lands on whomever the poor clinician is trying to provide care to answer that question. Maybe it's for a research project, maybe it's for a quality project. And at some point, our quest for so much data tends to kind of hit that inverse proportion, and we just lose the goodness of even our basic data. And I use urine color as a joke, but truly, do I need 37 colors for urine, or do I really need like the 5 that are most important for 98% of our patients? Someone has to be a gatekeeper and manage the how much do we collect. I think data elements are great. Lots of data elements are better, because I'm a big data girl, but that's a very different academic and theoretical conversation than what do we do to the folks who are at the patient in front of them and are trying to take care of them. And when you allow 1,000 data elements to be put in front of them for documentation, it really has an impact on care and user satisfaction. And at some point, that is too much data. We are gathering too much data, and there is a lot of it, especially in the nursing world, that provides almost no value, except to maybe the one person who asked it. So I will say that, and now I'll leave it to Sherry to offer her opinion before we get on to number 3 there.
Yeah, the one thing that comes back to me often over these last 10 years is I had a chief nursing officer say to me at one point when I said, hey, I have this information, right? These dashboards that the nursing directors, managers can go to. And, her comment was, Sherry, the nursing managers, the directors have so much to manage on a day-to-day basis, right? So patient complaints, large staff that, they're following up on, other information from a regulatory joint commission, and now you've added another layer to this. And we had gone electronic. Like I said, this was quite a few years ago. And so we'd recently gone electronic. I think it was around barcode MedAdmin or documenting in real time, and I was all excited to show them this data. And so what we have to be really careful about, what it makes me think of as I move forward with this, is let's ensure we create a dashboard that's not just the information from the electronic health record, but what are all those areas that maybe need to be pulled into one dashboard for them, so they don't have to go, oh, to look at this, I go to this website, intranet. To look at this data, I go somewhere else. That's a lot to keep up. Now, have I perfected it 10 years later? No, there's still those challenges. And I'm sure Rebecca has seen some very similar ones. So I think to your point, can there be too much data? Depends on who you're talking to and how are we presenting it to them so that it's as useful to be. Think if you're that pilot in the cockpit, and how data is presented to them so they can make the right decisions. Very similar to anyone that's actually leading or in charge of something. Let's always think about it from that pilot perspective. I had a UI human factors engineer I worked with years ago when I worked at McKesson developing electronic health records, who really shared some of that information with me and utilized that analogy around the cockpit and how can we present the information that they need in a very usable way. So what do you need right now, or what do you need to dig for?
So this is a really good point, right? And how the systems really help enable this, of course, but you alluded to this, Rebecca, a little bit earlier in your conversation about information blocking. So, and I might be giving you a question, both of you a question here that is a cold question. So my apologies for that. But thinking about the vendors in the market and how they might not all work together, what kind of experiences have you had so that you've been able to smooth past that, get the best out of those vendors in order to glean the information that you need to be able to have? Because data is in a lot of different places, and a lot of our attendees that come to our webinars are sometimes in the telehealth space. So data is contained even in a third-party system that might not even be in the EMR. So tell me a little bit about your experience with that and your ability, what have you done that you felt like worked well to be able to get these vendors to work together or to give you as much information as possible? And
you want to go first, Sherry?
Go ahead.
Go ahead, since you can go.
Okay. Sherry and I didn't share slides, but this is the fun of a Sherry Rebecca webinar.
Right.
Exactly.
So, I tell people I'll just throw my vendor out there. I work primarily with Epic, although I have a great love for Cerner and their essential data set in particular. And what I say is people want to complain about Epic all the time. They should have this, they should do that. In the nursing world, at least, I can't hardly get standardization from one ICU to the ICU across the hall at the same silly institution, much less across hospitals, across a city, across the nation. And so I tell people all the time, your vendor is not going to solve your self-inflicted wounds. So if you don't have standardized processes, if you don't have general policies for how things are framed in a note, in a flow sheet, in the requirements, and they always say, oh, we have state differences. Well, yeah, but 99% of things could be the same. Everyone is special. The more critical care leaning you go, the more special folks are. And it's really hard because a vendor, a vendor is not the AMA or the ANA or or ACOG. They are not a professional organization. They are not there to set those guidelines. If we could, instead of having 1,000 ways to do things, come up with better standardization, the major vendors, I think, would happily adopt that. They would be like, oh, thank goodness you guys finally got it together. Let us put this in our foundation system. And then magically, when you open it out of the box, it would work. And then the great part of that is your data and analytics would work. Most vendors give you a foundation system and they give you foundation analytics, And if you don't muck with it too much, those things work without a whole lot of extra stuff. You have to fix, hospital names and unit numbers and whatnot, but it's really hard. And so I find most of our major vendors to be very easy to work with. Most of those folks have clinical leaders who really want to do the right thing, but they can't clean up your fractured workflows, your lack of, interdisciplinary practice, your silos. There are a million, issues that have been issues for forever. And the EHR and the vendor that built it really can't fix those things. So I find them to be great, Michelle, when I can bring them a cohesive plan of what I need. But I frequently, it's like wrangling cats, and I'm sure I'm not the only one. So that's my thought on vendor relations and better systems.
Yeah,
Right.
I think it also adds to how good is your internal data and analytics team? Do you have a, chief data analytics officer? What is that? What are their strategies to get to that point, to pull that information together? That's where I've seen it work better at some organizations and other. And that add on top of that, a strong data governance council, which is what Rebecca was really speaking to there internally on, getting those areas to comply and also be consistent on the information that they're documenting.
Yeah, I think this idea of data governance is such an important piece that it doesn't matter what systems you're really talking about. Where is the data coming from? Which one we're going to call source of truth, things like that. Really important elements, regardless of what you're doing with those systems. Having a clean and strong governance of how you're going to handle that is so important. And so we do have times when the data, whether it's this information, blog, this ether that we have of data exists, and we get a lot of data. Sometimes it's too much, sometimes it's just enough, or it's potentially not in the right way, but sometimes it works really well. And I know that you all have some great examples here to talk about when the synergy of information and clinical work have intersected, and you've been able to improve the patient experience.
And let me, just before Sherry launches, because this is all her slide, I will say on that last slide, number 3, that we didn't really get to, but is a very quick thing, is when someone wants to put something in your EHR, you need to have a plan for how you'll know if it works as intended. It needs to be evaluated. And if it doesn't meet its KPIs or its objectives, it needs a process for being pulled out. If you don't do that, in 10 or 15 years, you will have an inordinate amount of garbage in your system, which just makes data and analytics significantly harder. So this is something, if you think about what can I do short term, if you can't go back and retrospectively pull garbage out of your documentation system, that's okay. Make a plan for not continuing to follow down that path, though. And that's all I got. So now I'll turn it over to Sherry and be quiet.
Yeah, no, thank you for going back to that. It's important to do that, to do that cleaning effort and point out this isn't giving us the information that we expected. So, for example, in some spaces, for us, a lot of us that are working in the telehealth space, as that's what a lot of what we do. The data that happens is if it's not comparable, to anything else, then get rid of it. If I'm not comparing that to a face-to-face, I have nothing to determine if it's successful or not. Okay, so I will stop as well and let Sherry speak about these examples, because I'm excited to hear about them.
Great. And actually what we'd love, as I'm going through a couple of these, if you all could think of some things, either you have questions for us on what you may be working on, or examples where it went well or when it didn't go well. So the first one I'm going to share around hospital-acquired pneumonia. One of my organizations really looking to improve this, as HAP is actually the second most common hospital-acquired infection that you get in the hospital. And so a couple of things that we really looked at, and I wasn't involved in this initially, it was our infection prevention leader and some others that were coming up with how we could improve this. So within usually 48 hours, when a patient's in the hospital, they can start acquiring pneumonia. So a couple of things that from a nurse that you can do is ensure the head of the bed is up 30 degrees, utilizing the inspirometer. So, coughing, deep breathing, oral care at least a couple times a day, any kind of getting up, moving. Also, what's their ability swallowing. So what had happened was our infection prevention leader, non-nurse, decided that in order for us to capture the data on if this was being done, it ended up becoming a documentation burden. So they added, we needed to document head of bed was up at least twice a day. Inspirometer was being used at least 8 times a day, and oral care 2 times a day. While this may sound like not such a big deal, well, they put in parameters also that some of this information needed to be captured by midnight. And you all know that our shifts are 7A to 7P, or somewhere in that 12-hour period of time. So by midnight, if you hadn't documented 8 times the inspirometer, it then failed. And if it failed once in that whole hospital stay, it failed completely. So we set the bar really low. That was one positive, meaning let's get 10% compliance, which I know sounds like really crazy. Why would you only want 10%? Well, you think about all those barriers that I just shared with you. And let's say the patient just got back from surgery at 1 p.m. You needed to get 8 times in there documented. Oh, and by the way, if you documented past midnight, that also didn't count in the approval that you actually completed everything that you needed to be done. So as I heard this, I said to my chief medical informatics officer, who also recently had become at that point the VP over safety and quality, I'm like, we can't, this is a huge burden on our staff to ask them. Well, at that point, it had already been approved through the board and how we were capturing the data, so I couldn't change that. But the piece of it, I'll also add to that, while we did meet that measure, one of the things that was interesting, and this is kind of where that Pareto also comes in, is if you asked our nursing leaders, hey, is oral care being done? Are they getting the inspirometer? Is head of bed up? It was like, oh yeah, those things are being done. So one thing that I thought about, and this is a data that isn't always captured through your electronic health record or something that's being documented, think about observation data. Think about being at the Gemba where the work is done. So I thought, here's a good way that we will know, since we implemented these changes, if it's actually being done. So how do you know if oral care is being done? Let's just think about the toothbrush. So I talked to Central Supply and I said, did we see an increase in toothbrush usage over the year that we had started this? And lo and behold, we had more toothbrushes utilized the first half of that year than all of the previous year. So the data is not always in that typical place of where you're thinking of, right? So that was a way to say to our nursing leaders and nurses, and plus we did see actually our hospital-acquired pneumonia really had decreased quite a bit, even though that percentage that I was telling you about was small. So in some ways, that worked well. We got where we wanted and is still continuing to improve, but you don't want to put that burden, as Rebecca has also stated on some of that documentation and what's being done, and then utilize those other opportunities, how to collect data. It's not always going to be done electronically. It could be observations. So that was one example. Another one, as I shared, being at a lean organization in my past, and they used a lot of visual management boards. So we had the problem of, we wanted to decrease our falls. We wanted to improve our patient satisfaction. And there's a lot of data there around rounding. So your nurses, nursing assistants should round on your patients at least hourly or every 2 hours, meaning going in and doing a very methodical round, not just, hey, are you doing okay, and leave. So in order to do that, we had implemented a new nurse call system, and there was data that came out of there because the nurses also wore tracking badges. So what the nurse manager did on that floor was, during every change of shift, there was a brief huddle at their visual management board to look at, was the nurses, nursing assistants in the room. If there was nobody in the room for that hour, that square was red. If there was somebody in at least a minute, but under 3 minutes, it was yellow, and then over 3 minutes was green. So every day they reviewed this. So as you can imagine, if you use this in a positive way and on a regular basis, not monthly, they were making changes daily. They could see, and the nurse manager would ask, okay, so no one was even in this room for 3 hours last night, or they were in briefly, during the day. It utilized that data in that real time, and not always in your electronic health record. It could be visual management boards that you put up, that you huddle in front of. It could be, a great example too is if you go to a basketball game and you didn't have a scoreboard, how do you know who to cheer for on who's not doing well or who's doing well? Think about that same thing. It has to be visible and that people know what the score is, not once a month, not once a week. In some cases, it could be daily or multiple times a day. So those are a couple of examples where you utilize it not only electronically, but where the work is being done. So it'd be great to hear from any of you on that.
Yeah, if there's anyone who is an attendee that has an example of how you've been able to or saw how data was effectively used in your practice, we would love to hear from you. You can put that question or that comment in the chat, or you can raise your hand and we can unmute you as well if you'd like to do that also. I think it's a really, it's such a good point that you're making, because when I initially think about healthcare data, the first thing I think about is data that's entered into the EHR as a result of charting by the nurse or the doctor or what, it doesn't, it is not intuitive to think about it in other ways in what you've just described, Sherry, and looking at a dashboard, and creating an observant data or observable data, and also in supply usage. I just thought those were really creative ways to use data. I can remember years ago looking at pharmacy information, pharmacy data, and usage of, before we had any kind of, and I'm gonna forget my terms because it's been a long time since I've been out of pharmacy, but we used to do a gentamicin review every morning and look at, how are the patients doing and where are, creatinine clearances and all that kind of stuff and the usage of that. And again, I'm gonna get my terms mixed up because I haven't been doing pharmacy for a long time. But that being said, that wasn't done. And we started to create that data collection and suddenly started to realize we can start to curb the use of this, this clinical treatment and improve patient outcomes as a result. So it's amazing what you can find out when you start to think through that.
And Michelle, it's Rebecca. I will say this isn't a population health conversation, but when you start to think about what goes in the EHR with the minimal amount of data that is patient entered, we're getting better with that, but we don't have a whole lot of it. In order to get that information in, you have to have a call to a healthcare provider, or you have to be in an office, or you have to be in an inpatient stay. And that inpatient stay has a finite start and end. The health of a patient, in quotes, health, has to do with, mostly things that don't happen in the doctor's office, don't happen in the hospital. And there are just multitudes of data sources related to, zip codes, social determinants of health, food deserts, air quality, lead-based paint, abatement in a living situation. And so when you think about how you're using data and analytics to really get a good assessment of a patient's health in the big picture. The EHR data is the least of them, and there are entire initiatives and predictive modeling initiatives that happen that are very accurate with regard to patients, and they don't use any EHR data at all. So that third party from the, running with supply chain to see how many toothbrushes you used to doing a quick touch point of a state database or police run data or EMS run data, you can find out a lot. And it's not just your EHR. So that's a side note in another lecture, but it's a good reminder.
Yeah, it is a good reminder. Absolutely. I'm going to ask about AI in a little bit, but I'm going to save that question because I know we have a couple of other data points that we want to talk about. And this is about the value proposition of data and how this matters. So maybe this is where my AI question lands, but I'll let Sherry, you and Rebecca talk about this a little bit and why this is important.
It's
you
Rebecca.
Want to go? Okay. I'm trying. I try to count. I'm learning to count to 10 and let other people talk. It's really hard. Executive coaching. All right. So yeah, value propositions. I just like to make the point that data looks different. And then on the next slide, there's a novice to expert thing where I'm going to wax poetic about how in medical school and nursing school and PTOT, everywhere you go, there's not a whole lot of emphasis on the basics of a data element, the advanced use of analytics. And when you get out of school and you hit your kind of progression to an expert in your clinical field, it is a very rare thing to find that along that pathway, we bake in competencies as it relates to data and analytics, much less technology and informatics in general. So it's important to bring back for the folks in your area where you work that data and analytics are not just a C-suite thing. They can go all the way, from bedside to C-suite. And I usually pick on something like, overdue orders. So you can have for your nurse who has 3 patients, a little dashboard or a color-coded report or some visual indicator on their screen that lets them know that of their 3 patients, 1 has overdue orders, and maybe those haven't been acknowledged in 30 minutes. And then you can roll that up for the charge nurse. So the charge nurse can have an overview of every patient on the unit and know exactly at a glance which patients have overdue orders past a certain time. And then you can roll that up and aggregate it for your nurse manager so they can look over weeks or months, and that can go up to the director who can see multiple units at a glance. That tells you about certain types of orders. It tells you about certain nurses who are consistently behind and why is that the case. And those data elements roll all the way up to the C-suite, and it's important that we focus on those executive reports, but those executive reports are built on, in a really good system, those things that roll right back down to the bedside. And so the farther you go down, the closer you get to the patient. We frequently forget to work with those folks. And maybe it's because we don't have a super user program. Maybe it's because we don't have built-in time and governance to work with people to make sure that we have data power users who are helping. But frequently when we talk about data and analytics, it's all this beautiful stuff for C-suite, but we forget that we really could be using our data and analytics to powerfully put information in the hands of our people at the bedside. And now that we moved into a mobile world, you can have those things going to the phone. It's amazing, but it's not frequently where we focus. And then the value proposition, this is a double-edged sword, number 2. Predictive analytics, cognitive computing, you can throw in AI. Non-traditional data sources like those non-EHR data points. The hard part with this is we don't have an educated workforce as it relates to data and analytics. And then once folks get in the hospital, we don't tend to extend their education in any way. So it's hard to get buy-in for predictive analytics. It's hard to get, I'm going to pick on nurses, sometimes it's very hard to get nurses to give up that Hester Davis or that Morse fall scale in lieu of this magical cognitive computing number, because to explain to them what predictive analytics are, to go through the variables that feed the model, to argue back and forth with them over why that 30-year-old set of 5 questions is really different than this thing we put together. It's hard. There is incredible value in it, but it is a hard sell. And if folks don't believe what you're handing them, then they won't use it. And frequently, I've been in a lot of hospitals. I find a real disconnect between the DMO, the data and analytics office, or the chief analytics officer, and all the people who work for them, and then the people at the bedside and who are managing those units. There is frequently not a great interconnection between the two. So there's a great value proposition. We can care for people more efficiently. We can have immediate access to problematic workflows, problematic employees. And by problematic, I mean those folks who fall outside of a norm, so that we can go try to see what's going on. Maybe they're better. Maybe they need extra training. The value proposition for data is not hard to build, but the use case to get people to buy into using data is frequently much harder. And that's really a cultural and education problem more than it is a data problem. But we can show great value. Getting to actually using data in the way that we, academically push is really hard in my experience. So my thoughts on value.
Sherry, what do you think?
Well, I agree with everything that she says. What I find interesting too, and I have a nursing informatics team here at Banner, and I think many times they just kind of get stuck on this traditional way of, I don't have the data, I can't show. Even before we even make changes or try to implement something, right? Name whatever it is, and it doesn't even have to be technology. We should be using data to show the value and then follow up to see, did it get you to where you want? It's kind of been a love-hate relationship over the last multiple years on the data and how many times have any of you seen something rolled out, but they didn't really have a clinician who understood what that data meant? I had someone that came to me recently and said, well, we had a physician review this. Well, that physician really didn't understand what this data, because it was more geared towards, let's say, nursing or care at the bedside. And so that's another just very basics. Be sure that whoever's reviewing the data is the one that's either going to be using it or really understands the process.
Yeah, an important point. I think about a nurse at the bedside, or even a physician working in rounding. There's so much, and again, I may be putting a question in here that is the cold question, but there's so much from a data at a glance that you referenced before, up to the minute dashboards, just trying to get quick information. But we also now have beds that are smart beds providing data. We have telemetry that's built in. We have Vocera people, and I'm picking a vendor there, but communications that are happening right around your neck while you're trying to take care of the patient at the bedside. Is there, and I'm pointing towards this reality of using data, but is there a reality of we have, as people, as humans, kind of have to process and prioritize? Is there any nursing studies or physician studies on the amount of information and how they're able to, we think, oh, this is great, I'll be able to talk immediately on my, on my neck, but maybe that's not always the best thing to be able to do. So I hopefully you kind of understand where I'm coming from with that question. And Rebecca's waiting her 10 seconds to answer, but Sherry, feel free to jump in.
I'll let her jump in.
Well, I'm curious, we have a really quiet audience here.
That happens.
Have we lost them?
No, not at all. No, they're all there.
Maybe we need to just take them all off mute.
Have there ever been any studies on that? On just that type of data that's coming in, all those different pieces of technology? I'm just curious.
Not that I am aware of.
Yeah, I'm not sure.
That certainly doesn't mean that it's not out there.
Right.
Yeah. Interesting. I'm hitting that extra bent that I got the extra wrinkle in my brain this morning on data. So how do we pick up the reality of data and the trust factors related to it?
So-
Okay, I'll start. Yes, go ahead, Rebecca.
Okay, yeah. Wait, I'm sorry. Sherry and I were just hitting each other up on text message. I was like, you take this one, but she's got the next couple. So I'll kick it off. You know, the trust factor is really easy for me. And that is this idea of a chief analytics officer, data management office is really a fairly new thing. And so the trust factor, what I mean by that is if you had someone who lived in the tiny office that used to be a closet, and that person has written all of your quality reports for the last 15 years, and then you brought up a chief analytics officer and created a whole new structure, and someone hands you an Epic or Cerner report. If we didn't engage you from the start and engage your little friend down the hall who lives in the office that used to be a closet, and we didn't get input and make everyone feel, this is just pure change management lecture here. If we didn't make everyone feel super comfy about the data, the validation of the data, probably make sure that your friend down the hall had lots of input and told you it was okay, then what we tend to do is stand up a whole new data framework, and you are still running down the hall to get your friend to do your report for you because you trust that friend. You don't trust the big EHR that we just spent $150 million to drop in. So trust and data, those are huge things. I work right now at the University of Vermont Health Network, which is a 2-state, multi-hospital, multi-types of hospital long-term care. We've got a whole array of things going on, but we had a whole institute that used to do data. And now we have Epic, and we have 1 million, reports, but I bet of the 200 we've published, people are probably using 30 of them, and they're still going to their data institute folks. And the crossover in the middle is really hard because the change management piece is painful. It requires champions, it requires sponsors. Most importantly, it requires dedicated, protected time where we didn't shove a new job into your already busy day. And it is validating and reviewing all of those data. And it's not okay to say, oh, we built a silo of a DMO and those folks will validate. No, the folks who use the data every day and the ones who used to do it for 20 years before you got the new system also need to be engaged. It's not a thing where you can do it in a silo, but that's frequently what has happened. So the reality of using data is we have a system, we have a whole framework, we've spent a ton of money. It still doesn't mean that it works seamlessly. And then the second part, that novice to expert, again, if your position descriptions don't have the first word about competencies related to the understanding of data and use of analytics or informatics, as I say, if it still looks the way it did, your PD from 1984, we need to update it. Those things should be baked in. Your clinical ladder for advancement, it should be baked in that you at least have a couple of competencies. How do we handle onboarding? How do we handle our framework for, power users for data, for super users for the use of the EHR? If you don't have those things baked in structurally, it's really hard to go back to number one and engage people to talk about data and analytics so they feel that they own it when they have absolutely no idea what you're talking about. And it is incumbent on us in operational leadership in the hospital to make sure that our brain is expanded to the point that we appreciate that these things are now a core component of practice. We give it a lot of lip service. We don't tend to really offer the education or the protected time for education and engagement. And so without those things, it's hard to have, you know, a reality of all these amazing data and analytics things that we talk about and that we like to trot around in PowerPoint slides. But when it comes to, you know, the rubber meeting the road, we just don't have the foundation there to make that happen. And that is a leadership issue, and it works all the way down. But there are some structural things you can do to try to make it better. And many hospital systems have not done that. So meeting the reality requires a lot of that foundational heavy lifting. And I find that a lot of folks don't really seem to have the appetite for that, but it's important.
Right, right. Good point.
Well, and you know, as we're at the end of this, and I'll share really, you know, what is data is just is facts, right? Statistics that are kind of collected together for a reference or to use for analysis. And how do you take that, I guess, as is to wisdom? And that's what hopefully Rebecca and I are sharing with you, some examples and getting, you know, some of this, of what we've done over the years or what we've seen, whether that's the change management, that trust, the review, all of that. So, okay, you were going to show that you can just kind of go through these pictures, and I'll just give the banner. This is in Phoenix at the Arizona Fairgrounds. We were the first one that set up. That was actually our freezers that are minus 80 degrees. At the fairgrounds, our pharmacy tent of where we're reconstituting the Pfizer vaccine. This was in, oh gosh, December, end of November, December, whenever it first came out, we were right there. And so, you know, what does this have to do with data and improvement? Well, we started out at giving about 800 vaccines a day, and through process improvement, looking at data, ended up with, now we're up to 2,000 a day in about an 8-hour period. Now, University of Colorado has did 10,000 in 2 days, which was, you know, even better. I'm not sure how many lanes they had set up, but we brought our process engineers and looked at just how are we bringing these cars in? Because everyone, they drove in, they ended up kind of coming, we had it inside in the fairground, big buildings, but just some changes in how that was set up, what was able to take us from 1,400 a day to 2,000 a day. So that's how we had utilized data in this process. And then also whether there are times I was just standing there timing, how long is it taking this team to get their customer through, where one could get it through in 2 minutes and another was taking 6 minutes. So then I'd go over and do some observations on why was it taking longer from one team to the other. Well, we had a very talkative physician that was giving vaccines that was taking him 6 minutes, and he was kind of doing a whole H&P, and I'm like, you don't need to do that. So sometimes that's where, like I was saying, it's just being there, watching, observing, even at registration, where were the holdups between we registered, we had observation outside, you know, the whole piece. So we're still doing it. We don't plan to stay we have 3 pods set up throughout Arizona that we're running, and we're hoping the state counties are going to take that over so Banner doesn't stay in the vaccine business.
Well, we appreciate, you know, what you've done. That's you drawing up the vaccine. And I know that, you know, you and your organization have been working hard in your communities, as has Rebecca's, as well as ours here in South Carolina and across the country. So it's amazing what data can do to help you process, improve, and even start to vaccinate even more people. So we can take away those nuggets of how to improve. So any final thoughts on why you love data so much, and why it's important to the healthcare industry and in our journey to care for patients in our populations? And I'll let you start, Sherry, and you can wrap up, Rebecca.
Yep. For me, now that as I I do report up through, as a CNIO, through our safety and quality. So in order for us to really move that dial, there's no way, right? How do we compare to other organizations or even internally between our 31 hospitals that we have? So it's been a big change I brought to Banner over the last 3 years, at least within nursing informatics, to really look at the data before we make the change, as we also ensure that the data is correct. So I'm on the I love data train today.
And Rebecca?
So my sarcastic answer is I love it because we do it so poorly. It means I'm going to have a job for a while, and I like job security. So there's that. But I mean, it's such fertile ground. It is, there are many things with patient care that we have done over and over again for decades. And there are so many disease processes that we really understand. But when it's time to do new stuff, I just think data is where it's at. I would love to transform nursing into way less, looking like 1984 questions and answers, but more observations aided by this incredible universe of data that we put at the caregiver's fingertips. And when we have things happen like pandemics or new unique, disease processes, I think data can really allow us to move forward so much more quickly and so much more comprehensively. And we just have to figure out how to get, for me, I feel like I always harp on the super unsexy things, but it's the education, the training, the buy-in, the willingness to let go of some of the documentation so that we can have better, cleaner, data starting points. And I just think it's a frontier that if we can ever crack it the way we need to, it's going to be amazing. And it's already amazing, even as poorly as we do it. So if we did it well, it would be just crazy and kind of limitless,
Yeah, you're right. I love that term fertile ground when you think about we're each individually doing a population health management in our individual areas of the country. But what if we were able to do that across the country? What if we were to be able to do that nationwide? What if we were able to drill down and up however we needed to and sideways, and maybe even across the world, and maybe at some point interplanetary data across? You're right. It's very fertile ground for lots of improvements and lots of opportunity there. Well, I cannot thank both of you enough for coming today and talking about data and why it's important to you and your organizations, and how we as individuals in our organizations can use data better, and gave us some good tips on how to improve our uses of data and where to find data in those unique and interesting ways. Thank you to everyone who attended this webinar today. I really appreciate it. This is Rebecca, Sherry's my email, obviously. We would encourage you to follow Blue Cirrus on LinkedIn, Twitter, and Facebook. We will also have this presentation. This is recorded, and the recording for it will be on our website before the end of the week. In addition, feel free to send questions that you may not have felt that you wanted to ask in this forum. I know that we had some comments from some of the attendees that you all did such a wonderful job. That's why they didn't have questions. You answered all of their questions along the way. Had a lot to think about. So tomorrow, if you have a question, feel free to email or chat, and we appreciate that. Thank you so much for being here. And as always, we want to thank our healthcare heroes, Rebecca and Sherry included, and anyone else on the line who's been taking care of patients on the front line and supporting those folks that are taking care of patients on the front line. Thank you for being here. Enjoy the rest of your week.
Thanks. Bye, everybody.
Bye, guys.